Welcome to the deep dive. Our mission today, well, it's total mastery. We're aiming for an elite professional understanding of this really complex, intimate relationship between the hepatobiliary system, the whole gastrointestinal or GI tract, and the profound effects of the anesthetic choices we make. This isn't going to be a surface skim. We are going deep. We're drilling down into, the microscopic architecture that dictates fluid movement, all the way up to those catastrophic humoral events that define life or death decisions in the OR.
Absolutely. This region, it represents a fundamental nexus of human physiology, the liver. I mean, it's the largest internal organ central to drug metabolism synthesis. It basically ensures that nearly every anesthetic decision you make is fundamentally a liver decision.
Right, the toxicity potential.
Exactly. The response to sedatives, coagulation support, and it all really hinges there. And any dysfunction, acute or chronic, it immediately brings in major comorbidities, dramatically amplifies risk.
Exactly. We're unpacking a pretty dense stack of sources today. We're covering everything from the basic structure of the hepatic lobule right up to that delicate chemical tightrope walk you need during a carcinoid crisis. It's a high-stakes stuff, no doubt, but we're here to extract that core professional knowledge you need, not just to know these facts, but to apply them confidently.
And our focus throughout this deep dive is really understanding the why, the underlying physiological mechanisms. That's what lets you truly grasp the principles behind perioperative protocols. So let's start a journey with the undeniable central factory, the liver.
Okay, let's unpack the liver's physical structure first. It sits, pretty safely, mostly protected, up in the right upper quadrant. Extends from ribs 7 to 11. But anatomically, when we talk procedures, the liver isn't just treated as one big mass, is it? What's the functional significance of the Kuno system, those 8 segments? Why do we need that seemingly arbitrary subdivision?
Oh, it's far from arbitrary. It defines the functional units. The Kuno system, it organizes the liver into these 8 segments based on how the hepatic veins divide it transversely and the portal veins divide it vertically. This system is absolutely critical for surgical resection. Think segmentectomy for a localized tumor.
Right, makes sense.
Surgeons have to know precisely which vascular inflow and biliary drainage systems go with the specific tissue they're targeting. That ensures the remaining liver tissue stays functional, stays perfused.
Okay, like defining the lines of commerce before you cut the highway. Got it. Now let's go microscopic. The hepatic lobule, that's the core unit. Plates of hepatocytes radiating around a central vein. But here's where it gets really interesting for, perioperative fluid dynamic transport. The contents of the portal canals and the nature of those sinusoids.
Absolutely. Within those portal canals, you find the essential portal triad. Hepatic arterial, portal venual, bile ductual. But just as important, you've also got lymphatic vessels and nerves in there. Blood flows from these vessels through the hepatic sinusoids, and these are highly specialized structures.
Yeah, they aren't typical capillaries at all, are they? Almost like a linky sieve that dictates a huge part of liver pathology.
Precisely. Their endothelial cells, the sinusoidal ones, have these large fenestrations, almost like holes, and they're crucial because they allow diffusion of fluids, large plasma proteins, other solutes, directly into the space of DISI. That's the space right around the hepatocytes. This architecture explains why the liver produces just a staggering amount of lymph. And it's nearly equal in protein concentration to plasma. So if there's a blockage, that protein-rich fluid backs up fast. And on top of that, those sinusoids contain Kupffer cells, highly specialized fixed macrophages.
The immune barrier.
Yeah, a massive immunological barrier. They phagocytize something like 99% of bacteria delivered from the GI tract via the portal circulation. They're really the body's essential first line of defense against gut flora getting into the systemic circulation. #tag B. The dual blood supply and regulation, the 7-5-25 paradox.
Okay, the liver's unique dual supply. Let's break that down. And the sort of paradoxical oxygen distribution. You really need to know these numbers cold to manage a patient with liver compromise.
Right. So the liver gets about 25% of the total cardiac output. That's massive. And the flow split is unequal. The portal vein, it collects all that venous drainage from the GI tract, spleen, gallbladder, pancreas. It provides the vast majority, 75% of the hepatic blood supply.
75%.
But because it's venous blood, it only supplies about 50% of the liver's oxygen needs. It is nutrient-rich, though. Conversely, the hepatic artery, branching off the abdominal aorta, provides just 25% of the total blood supply.
Only 25%.
But it accounts for the remaining 50% of the oxygen supply.
So even a modest drop in arterial pressure can critically endanger oxygenation, even if portal flow seems okay. Which leads right to the question, Why is the hepatic artery buffer response, the HABR, so vital in anesthetic management?
The HABR is just a beautifully effective, semi-reciprocal autoregulatory mechanism. When portal flow decreases, and this happens easily with volatile anesthetics causing systemic hypotension or, say, regional anesthesia inducing sympathectomy,
Right.
the HABR kicks in and inversely increases hepatic arterial flow to compensate. The goal is always to maintain total hepatic flow and, critically, oxygenation. If this mechanism is intact, the liver's pretty resilient.
But if it's impaired?
Exactly. If the HABR is impaired, say, by massive hypovolemia, high PEEP during ventilation, or extreme hypotension, then the liver risks ischemic injury. Our goal during anesthesia is often just ensuring we don't overwhelm or impair this critical protective response. ##C, metabolic powerhouse functions.
The sources really emphasize this. The liver is irreplaceable. No artificial device can duplicate all its functions. Let's dive into the core metabolic roles, starting with energy management.
Yeah, carbohydrate metabolism is absolutely central to glucose homeostasis. During fasting or stress, the liver rapidly mobilizes glucose via glycogenolysis liberating stored glucose. That's stimulated by hormones like epinephrine, glucagon, and crucially, it also performs gluconeogenesis, forming new glucose from non-carb precursors like lactate, pyruvate, amino acids.
And the clinical implication.
It's severe. Patients with advanced liver disease often develop profound, really refractory hypoglycemia. That's because of impaired gluconeogenesis and reduced glycogen stores. They also struggle to clear insulin efficiently.
Okay. Next up, protein and coagulation synthesis. For anyone in perioperative care, this is just the cornerstone of risk assessment, isn't it?
Absolutely critical, yes. The liver synthesizes virtually all plasma proteins, except for immunoglobulins. And more immediately relevant for us, it synthesizes the majority of clotting factors. Factor 1, fibrinogen, 2, prothrombin, V7, 9, X, and 11. Just remember, factor 8 and von Willebrand factor are mainly produced elsewhere.
Right. Now, what's the immediate clinical impact of reduced protein synthesis? Specifically, hypoalbuminemia. How does that change how we administer drugs?
Okay, reduced albumin synthesis dramatically lowers plasma oncotic pressure. This forces fluid out of the vasculature into the interstitium, that's third spacing, which significantly increases the volume of distribution, the VEED, for highly protein-bound drugs.
Which sounds counterintuitive, a bigger V.
It does, but here's the danger. Although the VEED is larger, there's a much greater percentage of unbound pharmacologically active drug available at the receptor sites. So you face the potential for an exaggerated toxic or prolonged effect even with a standard dose. This requires really careful titration, dose adjustment, particularly for highly protein-bound narcotics, benzodiazepines.
And muscle relaxants, too.
Yes, definitely. You also have to consider deficiency in plasma cholinesterase, which is also synthesized in the liver. That can prolong the effects of 6-phenylcholine and increase the potential toxicity of ester local anesthetics. #D drug metabolism and transformation. Right. The liver houses all that pharmacokinetic machinery handling exogenous substances. A key concept we have to grasp is first-pass metabolism. Orally administered drugs can be almost completely inactivated by the liver before they even reach systemic circulation. That limits their bioavailability, their effectiveness.
Okay, let's break down the two main steps, phase 1 and phase 2 reactions. This is really key to understanding drug interactions and potent sensitivities.
So, phasor reactions are functionalization reactions. They typically involve oxidation, reduction, hydrolysis, basically adding or exposing a reactive functional group on the molecule. This is primarily mediated by that huge variety of cytochrome P450 enzymes, the CYP enzymes. These reactions usually make a molecule lose its pharmacologic activity, unless, of course, it's a prodrug, which needs phase I for activation. They're essential for metabolizing things like inhaled anesthetics, propofol, midazolam.
And phase 2, the conjugation step.
Phase 2 takes that phase I product and covalently links it with a large water-soluble molecule, things like glucuronic acid or sulfate. This makes the molecule highly polar, really water-soluble, optimizing it for excretion in bile or urine. Examples there include metabolism of morphine, acetaminophen, and an important point. Many phase I reactions get impaired earlier in liver disease than phase 2 reactions.
Okay.
Which is why drugs relying heavily on phase I, like midazolam, can be extremely problematic in cirrhosis, whereas those relying mainly on phase 2, like maybe certain opioids, might maintain their clearance for longer.
This brings us straight to the clinical danger of drug interactions. Enzyme induction versus inhibition.
Right. Enzyme induction, driven by chronic use of things like ethanol, barbiturates, even ketamine. It increases the expression and activity of those CYP enzymes. This accelerates metabolism. Leads to drug tolerance, increased clinical requirements for co-administered sedatives, opioids, muscle relaxants.
And the opposite, inhibition.
Enzyme inhibition, caused by acute administration of drugs like, say, cimetidine, creates competition for the enzyme's binding sites. This decreases the rate of metabolism of the other drug, leads to elevated plasma levels, potential toxicity, or increased sensitivity. And remember, drugs with a high hepatic extraction ratio like lidocaine, morphine, meperidine, their clearance will drop severely if blood flow to the splanchnic circulation falls, which, as we know, often happens during anesthesia and hypotension.
Okay, shifting gears to pathology and risk stratification. There's a fundamental truth we have to acknowledge here. There is no single reliable test for total liver function. The liver's got this massive functional reserve, right? So significant disease can develop before the labs really reflect failure. How do we approach this lab conundrum?
We have to use the lab tests diagnostically. Try to differentiate between the two major categories. First, parenchymal disorders, which reflect true hepatocellular dysfunction, actual damage to the liver cells, versus obstructive disorders, which reflect dysfunctional bile excretion, usually due to a physical blockage somewhere.
Okay, so what are the key markers of injury we focus on, and how do we interpret them clinically?
The serum transferases, ALT, alanine aminotransferase, and AST, aspartate aminotransferase, are the most sensitive markers for acute hepatic injury. They basically leak out from damaged hepatocytes. Now, a crucial clinical nugget here is the ratio. An Gestalt ratio greater than 2 specifically suggests alcoholic liver disease or advanced cirrhosis from any cause as opposed to, say, viral hepatitis.
Interesting distinction.
Yeah. And critically, ALT is more specific to the liver. AST is pretty nonspecific. It also comes from muscle, red blood cells, kidneys, myocardium. So an isolated AST elevation needs careful thought.
And when we talk about markers of synthesis, what tells us the factory is truly failing to produce?
Albumin synthesis decreases in chronic disease, definitely, but its long half-life, 14 to 21 days, makes it unreliable for assessing acute injury. It's really a marker of chronic, significant damage. However, a prolonged prothrombin time, or PT, usually measured as an elevated INR, that is unresponsive to administered vitamin K that indicates severe acute or chronic liver failure.
That's a big red flag.
Huge red flag. It reflects the inability to synthesize those critical clotting factors. We also use ammonia levels specifically for evaluating hepatic encephalopathy, though, interestingly, the serum level often correlates pretty poorly with the actual severity of the clinical presentation.
Knowing the labs is one thing. Assessing real-world risk for surgery is another. We rely on composite scoring systems for that. Tell us about the Child-Pugh classification, still a cornerstone.
Absolutely. The Child-Pugh system remains a clinical cornerstone, mainly because of its simplicity and its prognostic power. It uses 5 features, grading severity from 1, mild, to 3, severe. Albumin level, bilirubin level, PT-INR, the presence and severity of ascites, and the degree of encephalopathy. The total score defines the class. Class A, 5 to 6 points, lowest risk, good prognosis. Class B, 7 to 9 points. And Class C, 10 points or higher, associated with pretty limited life expectancy. This classification strongly correlates with operative mortality risk. For example, for a non-laparoscopic biliary surgery, a cirrhotic patient's mortality risk is cited around 20%. Significant.
Wow. Okay. We also use the model for end-stage liver disease, or MELD, and the updated MELD-mean scores. MELD uses bilirubin, creatinine, and INR. Why did experts decide to add sodium, and why does that matter for us clinically?
Right. MELD was fundamentally designed to predict 3-month survival and prioritize patients for liver transplantation. The inclusion of sodium in the MELD score, that was a recognition that hyponatremia, specifically serum sodium, between 125 and 140 is a really powerful marker of advanced severe cirrhosis.
It's not just an electrolyte issue then.
No, not at all. It reflects the profound underlying systemic vasodilatory state and the high output cardiac dysfunction that's characteristic of advanced liver disease. Hyponatremia is associated with complications like severe ascites, increased risk of hepatic encephalopathy, and renal impairment. So including sodium refines the prioritization, helps accurately identify those patients at really imminent risk of death. Hashtag pathophysiology of cirrhosis and systemic effects.
Cirrhosis. That's the end point, isn't it? Regenerative nodules, fibrous bands replacing functional parenchyma. And structurally, that leads straight to portal hypertension. What are the major systemic consequences that stem from this backflow of pressure?
Portal hypertension results directly from obstructed blood flow within that scarred liver architecture. This impedance leads to a whole cascade of consequences across the splenic circulation. First, congestive splenomegaly. That causes platelet sequestration, leading to thrombocytopenia.
Low plate.
Yep. Second, collateral vessel formation. That leads to esophageal varices, placing the patient at immediate and severe risk of catastrophic GI hemorrhage. Third, and maybe most visibly, ascites. Fluid retention, driven by altered osmolarity and that critically low plasma oncotic pressure from lack of albumin.
And the most feared complication, often fatal, hepatorenal syndrome, HRS.
The HRS is. It's a truly brutal condition. It's functionally extreme renal vasoconstriction, even though the kidneys themselves are structurally normal. It's a severe complication of advanced cirrhosis and marked circulatory dysfunction, often triggered by acute events like GI bleeding, sepsis, or sometimes even overly aggressive diuresis.
Right, the management tightrope.
Exactly. It leads to progressive ascites, azotemia, oliguria. If you aggressively diurese to manage the ascites, you risk triggering the very renal vasoconstriction, that drop in renal blood flow that you're trying desperately to avoid. Definitive treatment is transplantation, of course, but supportive therapy is crucial. 4V albumin to maintain oncotic pressure, combined with vasopressors like midodrine, octreotide, or norepinephrine. The goal there is to preferentially vasoconstrict the splenic circulation, hopefully shunting blood towards the kidneys.
Okay, it's absolutely vital to recognize this. Anesthetic administration always carries the inherent risk of reducing hepatic blood flow, HBF, usually through reduced cardiac output and maybe some splenic vasoconstriction. What do the current volatile agents do to HBF, and why are some generally pressured?
Yeah, that's a key point. All volatile anesthetics reduce HBF, typically by 30% to 50% post-induction, primarily because they cause a dose-dependent reduction in mean arterial pressure, MAP, and cardiac output, CO. Halothane caused the most dramatic reduction. It's largely historical now, but good to know. Isoflurane and sevoflurane are generally the preferred agents for patients with liver disease. They seem to cause a minimal dose-dependent decrease and are thought to best preserve hepatic arterial blood flow and, critically, that HABR mechanism.
And desflurane.
Desflurane causes a moderate dose-dependent decrease in both the hepatic artery and portal flow. Really, the ultimate goal, regardless of the agent you choose, is to maintain MAP and CO sufficiently to prevent an ischemic insult to the liver.
Halothane. It's almost a relic, like you said, yet it's still mentioned. Let's just briefly touch on the severe risks of halothane hepatitis. Why is it still relevant?
Halothane remains essential learning because it highlights that drug-induced immune risk perfectly. Halothane hepatitis is a severe, idiosyncratic, immune-mediated reaction. We differentiate between minor injury, like a transient ALT elevation, and major injury, which is severe hepatotoxicity, even necrosis. The thinking is it involves the production of trifluoroacetyl, or TFA, halides during metabolism. These bind to liver proteins, generate neoantigens, and trigger an immune response.
And the risk factors.
The risk is significantly higher with repeat exposure, female gender, older age, and induction of the CYP-E1 enzyme system. Given the high fatality rate before liver transplantation was common, this historical case study really illustrates the necessity of careful agent selection in vulnerable patients. ###HeyB, other anesthesia-related factors.
Okay, beyond the volatile agent itself, what other factors that we control intraoperatively can impact HBF and even biliary function?
Opioids are a major consideration. All opioids have been implicated in causing spasm of the sphincter of Oddi. That's the muscular valve regulating bile and pancreatic fluid flow into the duodenum.
Right. Can mimic biliary colic?
Exactly. Or cause a false positive on an intraoperative cholangiogram. Generally, the more potent the opioid, the greater the potential increase in biliary pressure. Treatment for suspected spasm is multi-pronged. You can use opioid antagonists like naloxone or nalbuphine, or smooth muscle relaxants like anticholinergics, atropine glycopyrrolate, glucagon, or even nitroglycerin.
And mechanically, positive pressure ventilation, especially with PEEP. It seems counterintuitive, maybe, but it can severely compromise circulation to the liver. Can you explain that mechanism?
Yeah, this is crucial, especially for abdominal procedures. Positive pressure ventilation, particularly with PEEP, increases intrathoracic pressure. This directly impedes venous return to the right atrium, which drops cardiac output. Simultaneously, the increased pressure increases hepatic venous pressure, so you get this combined effect, decreased inflow and increased outflow resistance, which can severely impair HBF.
And ventilation targets.
You must maintain normocapnia. Hypocapnia and the resulting alkalosis cause generalized systemic and hepatic vasoconstriction, further decreasing flow. Hypercapnia and acidosis tend to cause vasodilation, which might sound good but can also be problematic systemically. So, normocapnia is key.
All right, moving to the plumbing system. The biliary tract is that critical excretory conduit. What are bile's three main sort of non-negotiable functions that really underpin its importance?
Okay, three main things. First, bile salts emulsify and enhance the absorption of ingested fats and, crucially, the fat-soluble vitamins A, D, E, and K. Second, it's the essential excretory pathway for substances like bilirubin, metabolized drugs, toxins. And third, it helps maintain duodenal alkalization. That's necessary for pancreatic enzymes to function efficiently.
That first function, fat-soluble vitamins, has an immediate pathology link for us regarding coagulation, doesn't it?
Correct. Impaired bile flow, cholestasis, leads to fat malabsorption or steatorrhea, and specifically a deficiency in vitamin K. Since the liver uses vitamin K to synthesize clotting factors 2, 7-IX, and X, this deficiency results in an acquired coagulopathy, often necessitates vitamin K supplementation preoperatively.
Makes sense. During a cholecystectomy, surgeons rely on navigating the Callet triangle. Why is this small anatomical area so, well, fraught with danger?
The Callet triangle, it's defined by the common hepatic duct, the edge of the liver, and the cystic duct. It's surgically notorious because it contains the cystic artery, and often, potentially, an aberrant right hepatic artery can run through there too. Dissection in this area requires absolute precision to avoid massive hemorrhage or, maybe worse, unintended injury to the main hepatic duct, which could lead to severe long-term morbidity.
High-stakes dissection. Finally, endoscopic retrograde cholangiopancreatopathy, ERCP. It's mentioned for ductal stones. This procedure often happens outside the main OR and requires specific anesthetic consideration.
EOCP is definitely challenging. The patient often needs deep sedation or even general anesthesia, but they have to be position prone, usually with the head turned sharply to the side, which really limits airway access. And the patient's cooperation is often needed, at least initially, for scope advancement. Plus, these patients frequently have active comorbidities like cholangitis or biliary pancreatitis. So the key anesthetic concerns are maintaining a secure, protected airway in a difficult position and just meticulous monitoring for hemodynamic shifts related to the depth of sedation or procedural irritation. ###int B, the stomach and ulcer disease.
Okay, the stomach manages large volumes, massive acid production. Let's quickly review the regulation of gastric acid secretion by those parietal cells.
Yeah, acid secretion is tightly regulated by three local stimuli interacting synergistically. You've got acetylcholine from vagal input, that's the neural stimulus, gastrin, the hormonal stimulus triggered by food and distension, and histamine, released from ECL cells, playing that critical paracrine-like role. And somatostatin provides the crucial negative feedback. It inhibits gastrin and acid release when the luminal pH drops to 3 or less, preventing autodigestion.
Peptic ulcer disease, PUD, strongly linked to H. pylori, we know that. But let's focus for a second on stress gastritis, or stress ulcerations, the kind you see after major physical trauma, sepsis, shock.
Right, stress gastritis results in multiple, usually superficial mucosal erosions, often after major physiological insult like Cushing ulcers, secondary to CNS disease, or curling ulcers, secondary to thermal burns. These ulcers absolutely require the presence of acid to form, so the core prophylactic treatment is maintaining the luminal pH greater than 5, using PPIs or H2 antagonists, because pepsin, the enzyme that actually breaks down the mucosa, is entirely inactive above that pH.
Okay. Now, what is the specific clinical complication of antacid therapy that the anesthetist really needs to be aware of regarding drug metabolism?
Right. The H2 antagonists, particularly cimetidine, are classic examples of enzyme inhibitors. They can interfere with the liver's CYP enzyme activity, potentially prolonging the effects of concurrently administered drugs that rely on that system for metabolism, things like midazolam or warfarin. Famotidine, conversely, is the least likely agent in that class to cause significant enzyme alteration. Good to know. And also, certain antacids, especially those containing calcium, can trigger acid rebound when stopped, or even lead to milk alkali syndrome, hypercalcemia, and metabolic alkalosis if they're overused. #C, esophageal pathology and aspiration risk. The esophagus, it's a relatively simple tube, really relies entirely on its two sphincters, the upper esophageal sphincter, UES, and the lower esophageal sphincter, LES. Failure of the LES leads directly to gastroesophageal reflux disease, or GERD, and chronic GERD in turn can cause Barrett esophagus. That's where the normal protective stratified squamous cells get replaced by columnar epithelium, a significant precursor lesion for adenocarcinoma.
So the core anesthetic challenge in really all GI surgery, but especially here, is aspiration prophylaxis, particularly in patients with existing GERD, achalasia, or those undergoing laparoscopic procedures where the pneumoperitoneum dramatically increases intra-abdominal pressure and consequently pressure against the LES.
Aspiration precautions are just non-negotiable. Absolutely. This means strict protocols like rapid sequence induction, RSI, with cricoid pressure to secure a definitive cuffed endotracheal tube, ETT. And we really have to emphasize the controversy surrounding the use of a laryngeal mask airway and LMA in patients with active reflux disease. It just doesn't provide the same definitive airway protection as a cuffed ETT and is often considered a relative contraindication in these high-risk patients.
Yeah. Moving on to the pancreas, an organ kind of tucked into the curve of the duodenum, performing this remarkable dual role. We know its exocrine function releases, 2.5 liters a day of alkaline juice, pH 8.3, plus those critical enzymes.
Yeah, the exocrine release is a beautiful symphony of hormonal signals. Secretin stimulates bicarbonate and water release. Cholecystokinin pancreozymin, or CCKPZ, stimulates enzyme secretion. These signals get triggered by the passage of acidic chyme, fats, and proteins into the duodenum. Then its endocrine function, housed in the islets of Langerhans, manages glucose via insulin from beta cells, promoting energy storage, and glucagon from alpha cells, promoting energy release.
Acute pancreatitis, described as a severe chemical burn, often triggered by gallstones or alcohol abuse.
What's the main pathophysiologic mechanism here? And how does this internal injury cascade into potentially life-threatening systemic chaos?
The core mechanism is believed to be the premature intraacinar cell activation of digestive enzyme zymogens, things like trypsinogen getting activated inside the cells. This leads to the organ literally auto-digesting itself. It's a massive chemical injury. This injury triggers an overwhelming cytokine storm, kicking off the systemic inflammatory response syndrome, or SIRS.
In the systemic effects. Systemically, this leads to profound third spacing and massive fluid sequestration, especially in the retroperitoneum. That results in marked hypovolemia and significant hypotension in nearly half the patients, maybe 40–50%. This circulatory dysfunction then predisposes the patient to acute respiratory distress syndrome, ARDS, and multi-organ dysfunction syndrome, MODS, and that's the main cause of mortality in severe cases.
Given this acute inflammatory chaos, what's the specific anesthetic note regarding pain management?
Well, we specifically try to avoid morphine, if possible. That's due to the risk of inducing sphincter of spasm, which could potentially worsen the underlying bile obstruction and stasis if gallstones were the initial trigger. Fentanyl or other synthetic opioids that tend to exhibit less spasmogenic effects are generally preferred for pain control in that acute setting. #tag B, intestinal tract and inflammatory bowel disease, IBD.
The small intestine. It's not just plumbing, is it? It's the largest endocrine gland in the body, responsible for 85–90% of water absorption. And the enteric nervous system, the ENS, is crucial. Contains as many neurons as the spinal cord. Allows peristalsis to persist even during high spinal or epidural anesthesia.
Right. When we consider disease, we really have to contrast the two major inflammatory bowel diseases, IBD. First, Crohn's disease. This involves transmural or full-thickness inflammation. It often affects the distal ileum, is characterized by skip lesions, so areas of non-continuous disease, and frequently involves fistulas and abscesses. This often leads to complex nutrient deficiencies, particularly B12, fat-soluble vitamins, zinc, magnesium.
So how does that differ from ulcerative colitis, UC?
UC is limited to the mucosa and submucosa. It typically extends proximally from the rectum, characterized by continuous lesions and almost always presents with rectal bleeding. Surgical intervention, a proctocolectomy, is often considered curative in UC, unlike in Crohn's, where recurrence is common. The acute danger in UC, though, is acute fulminating UC. This can rapidly progress to toxic megacolon severe colonic distension, usually greater than 5.5 to 6 centimeters.
An emergency situation.
Absolutely. Requires emergent surgery due to the high risk of systemic toxin release and potentially fatal perforation. #tag abdominal compartment syndrome, ACS.
Okay, here's where intra-abdominal pressure becomes a truly catastrophic mechanical event. Abdominal compartment syndrome, ACS, develops when intra-abdominal pressure, IAP, gets abnormally high, typically defined as greater than 20 millimeter Hg, causing organ dysfunction.
Right. Normal IAP is less than 10 millimeter Hg. At around 15 millimeter Hg, you start seeing early cardiovascular and respiratory perturbations. At 15 to 20 millimeter Hg, oliguria usually starts due to renal compression. Once IAP exceeds 30-40 centimeter H2O, you get reduced cardiac output, primarily due to decreased venous return and preload. It severely impairs diaphragmatic descent, leading towards respiratory failure, and causes marked diminution of renal perfusion due to direct glomerular compression.
The immediate treatment for confirmed ACS is urgent decompressive laparotomy, straight to the OR. But there's a severe, though rare, complication that can follow this decompression, reperfusion syndrome.
Yeah, reperfusion syndrome is characterized by a rapid onset of severe hypotension and metabolic acidosis immediately after the abdominal wall is open. It's caused by this sudden washout effect, the release of acidotic blood and all the accumulated byproducts of anaerobic metabolism from those previously compressed mesenteric beds suddenly flooding into the general circulation. Preparation for this requires meticulous pre-optimization, rigorous volume loading, correction of acid-base status as much as possible, and maximizing oxygenation before that decompression occurs. You have to anticipate it.
The spleen receives about 5% of cardiac output. And though it's often nestled safely under the rib cage, it's actually the most frequently injured abdominal organ, involved in up to, 60% of blunt trauma cases?
That's right. The spleen's functions include blood filtration, immune processing, specifically IgM production in the white pulp, and removing aged or abnormal red blood cells. Because its vascularity is predominantly arterial, a splenic tear can produce lethal hemoperitoneum incredibly rapidly. Trauma management becomes a race against massive arterial blood loss and the subsequent dilutional coagulopathy.
Splenectomy, whether for trauma or chronic conditions like ITP or hypersplenism, carries a major long-term risk that professionals absolutely must counsel patients about.
Yes, absolutely. The long-term risk is overwhelming post-splenectomy infection, or OPSI. As splenic patients have a significantly higher lifetime risk for life-threatening sepsis, particularly with encapsulated bacteria like pneumococcus and meningococcus. This is due to defective complement activation, specifically in the alternative pathway, which is normally crucial for clearing these specific pathogens. Preoperative vaccination protocols are essential for any elective splenectomy candidates.
Okay, let's conclude our deep dive today with the chemical bomb, carcinoid tumors. These slow-growing malignancies, usually found in the GI tract, appendix, jejunal ileum, are common spots composed of enterochromaffin cells. The danger lies not so much in their growth rate, but in their secretory products.
Precisely. The main mediators define the entire clinical picture. You've got serotonin, 5-HT, kallikrein bradykinin, and histamine. Serotonin gets metabolized to 5-HIAA, 5-hydroxyindoleacetic acid. That's the urinary marker we test for. Serotonin itself causes severe diarrhea, increased gut motility, and highly variable vascular changes, constriction or dilation.
And the most dangerous mediator for the anesthetist, bradykinin.
Kallikrein gets released, often triggered by sympathetic stimulation, and it acts on kinin precursors to generate bradykinin. Bradykinin is just a massively potent vasoactive product. It causes profound, often refractory vasomotor relaxation, leading to severe hypotension and that dramatic flushing. This hypotension is mediated primarily by increased nitric oxide synthesis. Histamine release, seen predominantly in gastric and foregut carcinoids, contributes significantly to the flushing and can cause potentially severe bronchospasm.
Carcinoid syndrome occurs when these mediators actually reach the systemic circulation, which implies they've bypassed something.
Correct. Normally, the liver rapidly and effectively inactivates these substances through first-pass metabolism. The syndrome occurs when these mediators bypass that inactivation, usually because the tumor has metastasized to the liver, dumping its products directly into the hepatic veins, or sometimes when the primary tumor drains directly into the systemic circulation, avoiding the portal system entirely. And carcinoid crisis is the life-threatening extreme form, often precipitated by factors we control. Tumor manipulation during surgery, chemotherapy, or critically, anesthesia induction itself. It's characterized by severe flushing, dramatic, unpredictable swings in blood pressure, cardiac arrhythmias, and bronchoconstriction. #B, anesthetic management in carcinoid syndrome.
Okay, the primary non-negotiable goal here is preventing mediator release in the first place. What's the central pharmacologic strategy?
Pretreatment and continuous management with long-acting synthetic somatostatin analogs, octreotide or lanreotide, is the drug of choice, absolutely central. Somatostatin binds to receptors on the tumor cells and blocks the release of these mediators. We use high prophylactic doses, typically 150 to 200 micrograms of octreotide, administered pre-surgery, and often continued as an infusion throughout the perioperative period to maintain that chemical blockade.
And we absolutely must know the contraindications. Which anesthetic drugs actively provoke mediator release and must be strictly avoided?
Right, strictly avoid histamine-releasing agents. Think morphine, thiopental, pancuronium, atracurium. And you must strictly avoid sympathomimetic agents like ketamine and ephedrine. That's because adrenergic stimulation is a known trigger for tumor peptide release, potentially initiating a crisis.
Even succinylcholine.
Yeah, even succinylcholine should be considered very cautiously. Its fasciculations can increase intra-abdominal pressure, which might mechanically squeeze the tumor and trigger mediator release, so best avoided if possible or used with extreme care.
If severe hypotension does occur during the case, which is a hallmark of the crisis, what's the preferred pressor agent?
Phenylephrine, a pure alpha receptor agonist, is preferred. That's because it directly vasoconstricts without activating beta-adrenergic receptors, thereby avoiding that stimulation that can trigger further tumor peptide release. You want to avoid ephedrine for that reason. Generally, a balanced general anesthetic technique is favored over neuraxial techniques to avoid sympathectomy. And aggressive monitoring, including mandatory arterial line placement, is absolutely required for immediate detection and management of those dramatic hemodynamic shifts. #tag88.
Wow. We certainly navigated a complex landscape today. We started way down at the microscopic architecture of the hepatic lobule, its leaky sieve dynamics, understood how our volatile agents impact hepatic blood flow by potentially jeopardizing the HABR, and we explored life-threatening pathologies from hepatorenal syndrome, the whole Kurzman's cascade of pancreatitis, right up to the really delicate chemical balance required during carcinoid surgery.
Yeah, the common threads running through this entire deep dive are pretty clear, aren't they? Maintaining hemodynamic homeostasis is paramount. Rigorous risk stratification using dynamic tools like Child-Pugh and Maldonado, understanding how drug pharmacokinetics are altered by hepatic function, especially those VD changes and enzyme inhibition pathways, and just constant vigilant awareness of organ system crosstalk. Mastery here really means recognizing that chain of cause and effect, that using drug X might reduce HbF, impair the HABR, and if the patient happens to be cirrhotic, potentially precipitate HRS. It's all connected.
The elite professional understands that managing HbF, aggressively correcting coagulopathy using the right factors or products, and rigorously preventing aspiration in these often highly compromised patients. These are foundational non-negotiable elements for success in GI and hepatobiliary surgery.
Absolutely. So, a final provocative thought for you to explore on your own. Given the rapidly increasing global incidence of non-alcoholic fatty liver disease, NMLE, and its severe form, NASH, which is already the fastest growing indication for liver transplantation, how will anesthetic and surgical approaches need to fundamentally adapt over the next decade? As more and more patients present for routine procedures with significant yet often previously undiagnosed underlying liver dysfunction. Something to chew on.
Definitely something to think about. Thank you for diving deep with us today. Join us next time for another deep dive tailored just for you.